In this part of the tutorial, we'll go through the data landscape and the currently published literature about the use of IVL for the treatment of peripheral arterial disease. The use of the peripheral IVL system for the treatment of heavily calcified disease was evaluated in the framework of multiple clinical trials, prospective trials, and most recently the results of the DISRUPT-PAD 3 RCT were published. The DISRUPT-PAD 3 trial is a randomized controlled trial which was performed in the US, in Europe, and New Zealand. The patients were randomized to IVL or PTA prior to DCB plus minus stent for the treatment of heavily calcified femoropopliteal disease. We had a 30 days follow-up documentation and the patients will be followed up to 2 years. A very important finding of this study is that the procedural success when we use the shockwave catheter is much higher compared to the success that we achieve when we use plain all balloon angioplasty for the treatment of these challenging lesions. Additionally, the use of the IVL catheter significantly reduced the frequency but the severity as well of dissections. As we see, we have a 77% relative risk reduction for severe dissections when we use endovascular lithotripsy. In the DISRUPT-PAD 3 observational arm, the shockwave catheter was evaluated across all different vascular beds, from the iliacs up to BTK disease. And all different lesions were also evaluated and included. It's very important that, that in the observational arm, we see that despite the inclusion of these very challenging lesions, we have a very good performance of the IVL catheter with a low risk for perforation, for distal embolization, and for dissection. A very important parameter is as well that the shockwave catheter was associated with exceptional results both for eccentric and concentric lesions as well as in long lesions and CTOs. Recently, a patient-level pooled data analysis of 5 already published trials was published. In this paper, we evaluated the results of the shockwave catheter in the iliacs, CFA disease, SFA, popliteal, and infrapopliteal disease. Despite the inclusion of very challenging lesions, we see that the shockwave catheter was successful in the treatment of calcified disease across all different vascular beds in all trials, and the risk for dissection was particularly low, which is very important, especially for lesions including non-stenting zones like the popliteal artery. Finally, what we see in this analysis is that across all vascular beds, we have a very low risk for dissections and very low risk for procedural complications like thrombotic occlusions, distal embolizations, and recoil.